Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I want to begin a series on rheumatoid arthritis. As I mentioned in the previous shows that I did on osteoarthritis, there are different forms of arthritis. Rheumatoid arthritis is one of them. It's an extremely disabling condition. It begins to affect individuals from the age of 20 up to 60. It affects more women than men. 4% women are affected, 2% men. Very, very common problem. In this country, 1.3 million individuals are afflicted with rheumatoid arthritis. Worldwide, 6,137,523 people are affected with rheumatoid arthritis. In this country, the whole yearly cost of rheumatoid arthritis is $19 billion. Very, very serious problem. Some folks reach the point where they can't even continue to go to work anymore. Very serious problem. Now, we still don't know to this day what causes rheumatoid arthritis. All we know is that it's an autoimmune disease that afflicts every single part of the human body, mostly the joint. And when you go to the joint, the soft tissues are affected, the bones are affected, the tendons are affected, so on and so forth. And then the swelling, and ultimately the joints become deformed, causing the need sometime for surgical reconstruction. Very serious problem. Now, there are, let me show you the frequent joints that are affected: the feet, the ankles, the hands, the fingers, elbows, wrists, shoulders, hips, neck, lumbar spine, thoracic spine, etc. Other organs that are most frequently affected, of course, the skin, the heart, the lung, the brain, the blood system, the kidneys, and the neurological system are frequently very affected. The signs usually are general malaise, fatigue, weakness, weight loss, aches and pain, and headache, fever, etc. Very, very, very serious problem. And of course, usually the individual will present with aches and pain in a particular joint, or feeling sick, not know exactly what is going on. And you will, of course, the physician will go on taking a history and do a family history, work history, very important, and will carry out a physical examination to try to figure out what it basically is going on. Now, what you have to understand, the basic problems that occur in rheumatoid arthritis is an autoimmune situation that causes an antigen-antibody complexes. And those complexes get deposited in different parts of the body. And then once they get deposited there, then they're called a local inflammation. That inflammation ultimately leads to the destruction or affects the area of the body that's involved to one form or another. If one takes example of the joint, the first thing that will happen, you have a lot of aches and pain in that particular joint, and then before you know it, the joint becomes swollen, and then the swelling persisted, and then ultimately the joint becomes affected more and more so, and that's when the problem arises, whereby you wind up having to do x-rays. The x-ray might show some inflammation. Depending on the degree or the length of the problem, then you'll determine whether the bones have been destroyed. At least the destruction began by first you see a malformation or deformation and so on. Then you will proceed, of course, to do the plain x-ray, CAT scan. Again, as I mentioned before, MRI is crucial. The plain x-ray is very important in that it will show the deformation, the deformity, and it also begin to show how the joint began to slowly destroy. However, when you do the MRI, it shows everything, including the tendon and all other stuff that are being affected. You know, and when one has a joint, there's a gel-like material that cushion the joint so that they don't rub against each other. Well, when you have this situation, that gel-like material is completely destroyed. So you have joint rubbing against joint. It is a very painful condition, very, very painful, and it extremely, extremely problematic. And that it can, as mentioned before, affect any part of the organ. Rheumatoid arthritis is a systemic disease, meaning that it may not present as arthritis. It may prevent that somebody's having some problem with their eyes, or they're having headaches, they're having neck pain, or they're having some cardiac issues. And then you go on to find out that they may have liver problem, kidney problems, the spleen may be affected. There's a condition called Felty syndrome, in particular seen in rheumatoid arthritis, where the spleen becomes enlarged. Once that happens, then you wind up with pancytopenia, namely low white count, low red count, and low platelet. In addition to that, the general inflammatory processes that are in play in rheumatoid arthritis affect the hematopoietic system, namely the blood system, significantly, because the inflammation wind up causing iron overload. And the iron overload is a double whammy, because the rheumatoid arthritis itself is inflammatory in nature. And then when you have secondary hemochromatosis, namely the ions piled up in the body, because the body cannot use the iron because of the inflammatory process that blocks the ability of the transferrin receptors to grab into the iron to carry it across the threshold into the bone marrow. That's not going to happen. So therefore the iron backs up. That itself, wherever the iron is piling up, that particular organ is being affected negatively. It can be piled up in the joint again, and that's a second problem for a joint that is already affected. So those are serious, serious, serious problems. So let's say, for instance, you're evaluating someone. They come in with aches and pain, you don't know what's going on, and then you proceed to do blood count, chemistry, urine analysis, etc., and then you do a sedate. The sedate is absolutely, completely, totally crucial. You have no idea. The field of rheumatology could not survive without this very simple test. Let me once again explain to you what a sedimentation rate is. All you do is that you will draw some blood, either in a heparinized tube or a tube that is otherwise anticoagulated. It's usually the lavender tube. Then you will take a pipette, remove some of the blood, and put it in this big hollow tube. It starts from 0 on top all the way to 100 at the bottom. That's right, from 0 all the way to 100. And all you do, you fill this long tube with the blood, and you stick it. We have a particular rubber-like material. We put it in so that it remains straight. That's all it is. And then you time it. You time it for 1 hour. That's right. You set it. After 1 hour, the bell ring, and the sedate is done. How do you read the sedate? From top to bottom. Wherever the plasma, in this case, because when your blood is anticoagulated, the liquid part is plasma. Wherever there's the level of the plasma meets the red blood cell right there, wherever that the two of them, plasma on top, red cell at the bottom, that's your sedate. Simple as that. And that test is the cheapest test you could do. And it is incredibly important because we're talking about an inflammatory disease. Whenever there's an inflammation and or an infection in the human body, the sedate is elevated. Period. There are conditions that can cause the sedate not to become activated. If you want to know what they are, there's a big chapter in rheumatoid arthritis in this book, and then throughout the book I talk about different things that can cause the sedate not to react and so on and so forth. I can't sit here and teach you all that stuff. And I want, in the first place, to suffice it to say, if it is at room temperature, it's got to be at room temperature. At room temperature, you did what I just told you. That level of sedate tells you the intensity of the inflammation. It tells you the intensity of the infection. The higher the saturation, the saturation is from 10 to 30. 10 to 30. The higher the level of saturation, the higher, the more intense the infection or the inflammation. Now, for students who, many of them watch the show, I know because they tell me when they come to the office, the saturation will not react. This is what I want you to write down. Were it not for fibrinogen. There are many, many phase 2 reacting protein in the body whenever there is an infection or inflammation. The phase 2 reacting protein that causes the saturation to work, write this down, is fibrinogen. That's correct. It's fibrinogen. If you have no fibrinogen, your saturation will not react. You understand that? This is something you should put in your back pocket because there are many, many circumstances in the field of clinical medicine where there is no fibrinogen. Afibrinogenemia is a medical condition. So when you are thinking about stuff, you have to put all the pieces together. You just find out what causes the saturation to react is the fibrinogen in the blood. Without that, the saturation will not react, period. Keep that in mind, okay? So, I just finished telling you it's an antigen-antibody complex that caused the problem. How does that work? Well, the antigen-antibody complexes together, once ever they form, the body reads them as a foreign substance. That's correct. The body is reading these complexes as a foreign substance, and the body reacts against it, and you have the inflammation. How about that? Let me repeat that. What's causing the problem is an antigen-antibody complex that together, they join together. What is an antigen? An antigen is a substance that a physician or head of healthcare professional will inject into you, such as vaccine. When you're getting a vaccine or the flu shot, you're basically getting an antigen. And then the body, after X number of days, will react to it. Okay? And that's it. Okay? To produce an antibody. Whenever you inject something in someone by way of a vaccine or a flu vaccine or whatever it is, you are basically injecting the antigen. And then an antibody is going to react to it to protect the body. In this case, in an autoimmune situation, those are an abnormal. God only knows these things. There are thousands of autoimmune diseases in the clinical field of medicine. But we're talking about rheumatoid arthritis. With all the incredible knowledge, scientific thing that's being done across the world, we still don't know what's causing rheumatoid arthritis to develop. Suffice it to say, now that you understand the concept, the body is reacting against it, and you have a local inflammation, or for that matter, a diffuse inflammation, because the inflammation can get loose into the bloodstream, causing all sorts of bizarre things to happen. So when I said last week, I'll repeat it again. Arthritis is not necessarily always arthritis. Just because somebody comes in with headaches, dizziness, insomnia, a little bit of depression, aches and pain, it may be the beginning of rheumatoid arthritis. So you don't know that. So you have to take a complete, thorough history, and then you're going to do a complete, thorough evaluation. And then there's certain tests. I just mentioned the saturation. One of the most crucial tests to specifically diagnose rheumatoid arthritis would be the rheumatoid factor. That's right. In rheumatoid arthritis, the rheumatoid factor is elevated, very high. So whenever you think it's arthritis, you must always do your saturation, which helps you to understand the intensity of the problem. It also helps you to manage the patient, because as you're treating the patient, the test that is most important for you in the management of the patient is the saturation. You see the patient 1 month, they're coming back to you next month, you give them a piece of paper, a week before they come, they do a sedate for you, or a few days before. That tells you, or you could look at the joint, it's not as swollen, and blah, blah, blah. But the sedate will tell you if your medication is working or if it's not working, or if it's working, to what degree it is working. You see how simple that is? All right, now, so therefore then, you almost always keep your eyes wide open so that the patient comes in with a painful swollen joint. You're going to examine, you're going to take a history. There's no accident, no injury. Take a family history, a job history. Did you pull the joint on one form or another? You're going to finish taking the history, do a complete thorough examination, including the skin, because the skin is the largest organ in the body, and there are some bizarre findings one can see on the skin on somebody who have rheumatoid arthritis to one degree or another. Then, of course, the specific joint in question is going to be evaluated by you. You're going to palpate it. You're going to move it around, see how the patient reacts, and so on and so forth. Then now that you've done all that, then you're going to do a complete blood count. The blood count is a CBC that has the white count, the platelet, the red count, and the differential count. And in some instances, depending what kind of lab you're dealing with, you have a whole lot of other data that can come as well. Then we do a complete blood chemistry profile, which involves the kit that will evaluate the liver for you, evaluate the kidney for you, and so on and so forth. You do all that. It's important also to check the lipid. Yeah, you check the lipid, and then it's super important to check the urine analysis. You check for protein. You check for blood. Then you look at the urine under the microscope to see if certain things that we could see, such as cast and other debris that you couldn't see at the microscope, that can be because the kidney's been affected. That's why you're seeing all this material under the microscope. The albumin is super important. The sugar is super important. So you do all this stuff. So now you do a sedate. You do a rheumatoid factor. Okay? You go ahead and do a vitamin D, and we'll get to that another time why the vitamin D is important. Okay? You do all this stuff. It is always important in a setting like that to do an ANA, anti-nuclear antibody. Very important, because sometimes the rheumatological problems are multifactorial. Okay, overlap syndrome, right? You could present with rheumatoid arthritis. The next thing you know, it is rheumatoid, but there's another type of arthritis associated with it as well. So the only way you're going to know that, you do your sedate, because you have to rule out things. Because sometimes lupus, which I'll talk about in some other shows later, present as arthritis. That's right. So therefore, by doing the ANA, by doing the ENA, by doing all this stuff, then you are eliminating things or you're adding things. So those are the basic. You do your rheumatoid factor. You do definitely do your ANA, your ENA, and your sedate, and all these things. And then in certain instances, depending on your index of suspicion, you may wind up to do protein electrophoresis as well. Very important, because as I said, there are a whole host of other conditions that present first with pain. Multiple myeloma can present first with pain on the bone, and so on and so forth. So not wanting to take any chances, and depending on the ethnicity of the individual that you're dealing with, you do hemoglobin electrophoresis. You do a serum ferritin, because the ferritin is going to tell you if you have iron overload, the serum ferritin is going to be very high. If the person presents with joint pain of one kind or another, you do hemoglobin electrophoresis. This may be the first time you're going to find out that this patient have abnormal hemoglobin that he or she was born with, that nobody before has ever tested. I practice it. You have no idea. I have diagnosed 70-year-old, 75-year-old folks in my office with abnormal hemoglobin that nobody knew before, because nobody bother to check their hemoglobin electrophoresis, which is something you should do depending on the ethnicity of the individual. You don't know who these people are. You're seeing them for the first time. They may be from Greece, they may be from Italy, they may be from Africa, they may be from India, they may be from the Middle East. How in heaven you're going to tell me what are bothering these folks if you don't do things that can be associated with them? You cannot properly practice medicine. I don't care what anybody tells you. You could do fancy surgery, important surgery, because the organs, most of the time, 99.9% of it are found in the same place. And they are excellent surgeons, but you cannot practice general pediatrics. You cannot practice general internal medicine on someone whose ethnicity, that not only that you well aware of it, that you're also sensitive to it. You got to be familiar with the ethnicity. You have to be sensitive to the ethnicity. Otherwise, you're not going to provide quality care. I don't care how smart you are. There is no question there are a whole lot of brilliant doctors out there, but you have no idea. You have no idea the stuff that are not being picked up because people are, when you go to medical school in the United States, which is what I can be familiar with, you are taught medicine using the white folks Anglo-Saxon system. That's right. That's the system. But listen, you have to understand, I will repeat that. The world has 7 billion folks on it. 4 billion of those folks live in Asia, different part of Asia. 1.5 billion live in Africa. That's 5.5 billion right there. Okay? And I have not touched Europe. I have not touched the Americas. And you're going to tell me that you're going to ignore all these folks who are afflicted with different types of diseases, who present with different part of symptoms, because the world people on Monday, they're in Europe. Tuesday morning, they're already in the United States or wherever. People are traveling back and forth, and these people might wind up in your office seeking medical care, or in your hospital seeking medical care. And you're going to apply only the knowledge that you got here, dealing mostly with black folks, to them. You got to be kidding me. And this fact that I just mentioned to you has now been accepted by the powers to be in the United States of America, to the point where the AMA several years ago has been given grants to several medical schools so that they can change the way they teach medical students, the way they train house staff to incorporate the stuff that I just tell you about. So this is just me saying these things so that people can turn on me or say, Val is saying back things about us. The power is to be the people who run, as a matter of fact, there are certain states you are obliged and obligated to take an ethnic sensitivity part of your license exam. How about that? Okay? So it isn't just me saying these things. Yeah, I'm an author. I spend my days when I'm not seeing patients or taking a few hours of sleep, writing, reviewing the literature throughout the world. So I know what I'm talking about. You can't sit down here and write this big book, African American Men's Health. Nobody else has written this book, 113 chapters. I don't know what's happening in the world of medicine in the world. Because this book applies to all men of color. Just because I entitled it African American Men's Health doesn't mean it was just written for African American men. You got to be kidding me. This book applies to all men of color across the world, period. No matter the diseases that affect them, you're going to find some of it or most of it in this book, so on and so forth. Another issue, different people, because of culture, eat different food that can make them bad, good, and can also make them sick. Different people, because of culture and religion, have different dietary habits. That can be the reason why they're present to you, because they're deficient in certain things that based on their religion, there's certain food they don't eat, and therefore they can be deficient in certain vitamins and certain stuff. How are you going to know these things if you're not paying close attention? And machine cannot always diagnose things for you. 70% or more, roughly 70 to 75% of what physicians do every day is based on their experience and knowledge. How about that? So therefore, rheumatoid arthritis then, while I just finished telling you how to go about evaluating it, may not necessarily be just rheumatoid arthritis that you're dealing with. It may be rheumatoid arthritis in conjunction with, or it may just be rheumatoid arthritis. But if you just have this tunnel vision and sticking to it, you're going to miss a tremendous amount of very crucial and important diagnoses and other things that are affecting people. And you can't practice that way. I don't teach that way. The folks that I teach, first of all, I take this teaching thing extremely seriously. I don't play games. When I agree to do something, I'm going to do it 100% correctly. Once I say yes to it, my yes is yes. If I say no, my no is no. So therefore then, you got to do all these tests that I just mentioned, order the x-rays based on your judgment, CAT scan, MRI, whatever, and then all these results is going to start coming back to you. And by next week, I'll sit down and begin to interpret for you the different results as they start coming back and dealing with this patient. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.